healthcare Canadians get within the country can vary depending on where you live.
My children don't know what it was like to have a doctor. You know, they sit in outpatients, they wait for hours.
With the amount of people in need, wait times to see a mental health professional through the public sector are becoming a problem.
Racism in healthcare has been acknowledged by medical professionals, governments, and advocates.
But this is Canada. We have some of the best healthcare in the world, and it's for everybody, no matter what, right? Or is that just something we like to tell ourselves?
Yeah, rewind that. Rewind that. Yeah, rewind that. Rewind that. Yeah. Rewind that. Yeah. Rewind that. Yeah. Rewind that. Yeah.
My name's Louise Lemire-White, and I'm a parent of 4 children. They're all adults now. I am a registered nurse. I work in a hospital, downtown hospital in Toronto, and I am the co-founder of an organization called Families for Addiction Recovery, or we like to call it F.A.R.
So Families for Addiction Recovery, or F.A.R., was founded 3 years ago by parents whose kids have struggled with addiction from an early age, like early teens. And it was founded because the needs of our families are not being met.
Our children were struggling with concurrent disorder, mental illness, and substance use disorder. And there was no access to help. We needed immediate help. We needed timely, compassionate, evidence-based, accessible, publicly funded treatment options for our youth. And there was none.
A lot of people will tell you that addiction doesn't discriminate, and that's true, but recovery absolutely does discriminate. You're much more likely to be able to recover right now in Canada if you have money, because there are huge wait lists. I think we're supposed to have universal health care for mental health and addiction. In reality, we do not. So there are long wait lists, and as actually a representative from the Ontario Ministry of Health said to me, you know, a wait list can be a death sentence when it comes to addiction. So people who have money essentially can jump the queue, and that's not right. We're lucky. Most of us are professionals. We had money, and we could do what we needed to do to ensure our children got the help and the care that they need. That's just not available to most Canadians. And honestly, it's why I'm not in retirement right now. I retired as a lawyer, but I am now a full-time volunteer for F.A.R. in order to ensure that we have universal health care for people struggling with mental health and addiction, and we break down all the barriers, and we ensure everyone can get evidence-based treatment, you know, timely, and it's accessible, and it's compassionate, because a lot of the problem is stigma even within, unfortunately, the medical community.
During med school, I needed a part-time job. My younger brother actually worked at the local homeless shelter here. So he was able to connect me with their detox floor there. And I started doing some overnight shifts and some weekend shifts at their detox. And I started to see kind of from a frontline worker's perspective, the issues that were affecting people who use drugs and kind of the lack of resources available to them in our community. So at that time, I did intend to be a family doctor, but I think that experience working at the shelter really shifted kind of the focus that I wanted to take in my family practice. And then once I graduated and I was practicing, I actually started in that same homeless shelter. And again, learned from a physician's perspective, kind of the lack of resources that patients had who were using drugs, and kind of felt on a daily basis just like I was knocking my head up against the system every single day. So through those experiences, started to try to think about how we could do things differently to serve people who use drugs. Most of our services are set up to be accessed with people with certain privileges, right? So if you're living in a downtown shelter and you don't have even geographic access to a family doctor or hospital services, transportation to get to those services, kind of the daily normal scheduling that those of us, you know, who have a normal schedule take for granted in terms of waking up and going to bed and being able to get to appointments at certain times, even those very basic inequities were huge barriers to my patients. Let alone the inability to kind of navigate the hospital system or to be treated by respect by all manner of employees of the hospital and physicians, to be able to articulate their own needs and get what was culturally appropriate care to them. All of those were barriers, let alone then the actual medical treatment that we were trying to get them access to. I think healthcare is great and accessible to people who fit the model of care. Right? So I think a lot of people who use drugs are kind of people who struggle with health inequities, often get a label of behavioral problems. And most of that is actually just related to the way that we expect them to interact with the system. So I think when we turn around and kind of look at the system from their perspective, we can start to do things differently so that they can achieve care just like us. When we look at the opioid crisis, what we have is an overdose crisis. And people are overdosing and dying because they don't know the strength of what they're getting or the amount that they're getting. So by giving somebody an opioid of known dose and known potency, they're much more able to regulate their use. And when people know the amount that they're going to use, they can do so much more safely and then hopefully prevent overdose and death.
I really want to be clear that we have regularly people dying every month, every day. I've been losing my patients who are very young people more and more over the last 10 years.
We had the first case of an epidemic of overdoses in 2014 in Montreal that lasted between May and June 2014. That was the beginning of our situation of overdoses, and then it was the first time in Quebec that we had kind of a case like that, and we start in epidemiology study to understand what was going on and to be able to describe the situation, but not only that, but we start the plan of prevention for Montreal because we find out that we needed to go forward with all, intervention, including naloxone and others, to respond to this case.
People who inject drug in particular really are having a very hard time getting the care they need in the hospital, getting their withdrawal taken care of, having the medication they would be ready to take. For example, if they wanted to start methadone in the hospital, it's not feasible. So I would say the hospital and the prisons, the provincial prisons, are still the two places where we are missing so many opportunities to give people help and to have this conversation. So a lot of stigma. going around still.
We did many studies to try to document the needs expressed by drug users. We did 2 or 3 between 2000 and 2008 to try to show the needs to implement the supervised injection services. But as you know, Insight, who opened in 2003, had difficulty to obtain their exemption under the federal government at the time.
It's like all the evidence and all the science that we have is never worth or is never enough to legitimize harm reduction. So, I mean, we have studied our intervention over and over again. So, I mean, if you were diabetic and I had an intervention for you because you had tried all the oral molecules, and I had an intervention for you that was injectable, and that was so evidence-based that I knew that you would be retained in treatment at 80%, and with the oral it's like 50 or 40, you would be more retained, you would spend less money, less criminal activity, you would die less. And if I would not give that to you, I would be like, people would throw rocks at me. It would never be possible. And we do have this in the harm reduction science intervention. We have the data, like full-blown data. And we have still to struggle to implement these interventions.
What happened is in 2011, the public health director at the time published a report on the STDs, HIV, and HCV in Montreal, and it was really clear that we needed to better implement harm reduction measures in Montreal, and then the supervised injection services came on the list as the next step. So we started a feasibility study, a complete one. We worked with more than 100 persons. We did another consultation with drug users among more than 105. We did a big tour with my director to visit all the stakeholders, politicians of all levels, federal, provincial, municipals. We conducted focus group with police, with directors and patrollers. And so at the end, we were able to say that we had the recommendation that went to the Administration Council of the Agence Régionale de la Santé at that time to recommend formally to implement these services with recommendation of how to do it. And during that time, as you remember, at I think it was September, October 2011, the Supreme Court supported the implementation and the renewal of the exemption for Insight. So for us, it was kind of a very pleasant day, because then that was the first time that we saw maybe a possibility of going with our project in Montreal.
The ultimate goal would be, probably, or one of the most effective would be legalization and decriminalization, because then rapidly it would lower health inequalities and people would be less going through the justice system. They wouldn't have to hide. They wouldn't be seen as bad people doing illegal things. So that would rapidly go into a lot of the issues. But that's very difficult political commitment. But I think we've tried so many things up to now, and we see that we cannot get over with the epidemic. So I think we need to start to have this conversation.
My name is Sheila Jennings. I am a lawyer by training, and I recently finished my doctorate in looking at the law of support for mothers with severely disabled children, and I am the Ontario lead for Moms Stop the Harm. Moms Stop the Harm is a national network of approximately 900 moms and families. Members include our children who have passed away from substance use or who are currently struggling with substance use or actively seeking recovery from substance use, from harmful substance use. And we advocate strongly for an end to the war on drugs. And we are focusing right now on our efforts to work with allies to establish new laws for safe supply. So one thing I do recall is with Rob Ford, when he was campaigning, the brother of Doug Ford, he referred to the people as taxpayers. And the sense that one gets is that if you are not a taxpayer, you don't necessarily count as being one of those people for whom policy is going to be focused on. Another thing I will say as well is that one of the things, that's come up for me is a framing of things. So Mr. Ford, for example, went to New York a few months ago to announce, Ontario is open for business. And there's nothing wrong with that per se. But Ontario is about more than just business. And that's sent a message out, however. And so in Kitchener, very recently I read in, I think it was CTV, about a woman who was got a petition together and a letter to send to Mr. Ford to say that they don't want a safe consumption and treatment facility in their area because it's bad for business. And there's this dichotomizing now with that of what's bad for business and what's good for business. Death is not about business. Death is something else. Becoming brain injured isn't about business. Having endocarditis is not about business. Having compartment syndrome and massive abscesses and HIV and Hep C and being beaten up on the street, that's not about business. So I think it's a very powerful framing, this continual talking about what's good for business. This is about marginalization, impoverishment. It's about a whole bunch of other stuff that happens when this focus stays over here, narrow focus on business.
So in Manitoba, we have a bit of a conservative province, so that means harm reduction has been a bit slow on the uptake. The population itself is very much feels that we shouldn't be supporting people who use substances, that they should just be getting addiction treatment. That being said, there are a couple great programs in Manitoba that have been offering harm reduction services. So outside the city of Winnipeg, there's the Manitoba Harm Reduction Network, and they've been doing some great work around the province. Within the city, there is the Winnipeg Regional Health Authority has a healthy sexuality and harm reduction branch, and they're essentially the main distributors of needles and safe injection supplies around the province. And in addition to that, a lot of clinics around the city have also started distributing supplies as well. So 9 Circles, Clinic with a K, they've been doing a lot of supply distribution as well. So harm reduction is here in Manitoba, but it's a bit slow on the uptake compared to other provinces, especially BC. So I'm a nurse, part of an organization called the Harm Reduction Nurses Association. I'm actually a central regional representative for all harm reduction nurses. So I represent nurses in the prairies. And so I've been a part of that organization for about 1.5 years. In addition to that, I run a program called Project Safe Audience. We're a harm reduction initiative that targets high-risk behaviors in the rave or the after-hours music community. So we go to raves, we test people's drugs, and do on-site drug checking. We also do supply distribution, give out condoms, lube, earplugs, as well as safe snorting equipment. And we just kind of be a safer presence at these rave events. When it comes to the sort of the 4 pillars of drug policy, so that's addiction, harm reduction, policy, and prevention, Manitoba seems to sit with the prevention, addiction, and enforcement side, and they haven't really acknowledged this harm reduction side. So a lot of the times when I bring up this idea of harm reduction, a lot of these organizations would essentially ignore this because they don't want to acknowledge that people can use substances safely. They believe that if anyone's using substances, that should be stopped and everyone should stop using these substances completely. But what time and time again has shown is that that's an impossible goal. Stopping people from using substances is not something that we're going to be able to do. So that's where harm reduction comes in, and that's what I'm trying to do with my organization. Really, the federal government is sort of taking a stance on harm reduction and being positive, but at the provincial level, where there's a lot of barriers at this, so people cannot access universal care across Canada. So the care for someone in Manitoba who uses substance would be vastly different than the care of someone in BC would use for substances, and that's a big issue. Like, we should be able to provide the same level of care across Canada, and that's just not the case. And it's very unfortunate that the barrier itself is a lot of the time is the provincial government. That's not fair. It's not fair for the people of Manitoba. A large amount of the clients I work with are Indigenous, and it's a struggle. Like, they are very much disproportionately affected by this issue. They find barriers to accessing care, barriers to accessing services, and there's not a whole lot of sort of culturally sensitive care that are focused to that population. And because of that, they are quite stigmatized as a whole, as a whole in this province, which is quite unfortunate. The main substance of choice inside the province of Manitoba is methamphetamine, and a lot of my clients use it for its protective mechanisms. Like, if you fall asleep, you are at risk of getting your stuff stolen, and I've heard that time and time again. Also, when you don't know when your next meal is coming, it makes sense that you'd want to take a substance that sort of prevents hunger, and that's something that these people use for sort of its protective mechanisms. And honestly, if your life is where you always have to protect yourself, it makes perfect sense that you'd be using a substance like meth. And a lot of the times that people don't really find themselves safe in a lot of the shelters around the city, so they will stay on the street because they can use their substance there and stay awake and be able to protect their goods. Most families have someone in their family unit that uses substances, and really this overdose issue across Canada has affected all substance-using population, not just the opiate population, but the stimulant-using population as well, and even the party drug-using populations as well. So getting the Narcan and naloxone training can really help benefit the average citizen to getting a good understanding of what harm reduction is. As for the Prime Minister and sort of the higher levels of government, I think what needs to happen is more funding towards peer-based organizations. A lot of the times, a lot of this funding will go to these sort of large health organizations who have good ideas and they want to put them before us, but people who use substances know best how to treat people who use substances. So that's where a lot of the funding should go. And that's why I'm a huge fan of a lot of these peer-based organizations. And in Manitoba, we have like the Manitoba Harm Reduction Network has a peer-based side of it as well. And a lot of the Nine Circles Health Center has a peer-based group that works with Nine Circles so they can better provide services. And that's where I think a lot of the funding should go, not to sort of these larger larger groups, but to these groups that offer peer-based services.
Ladies and gentlemen, the leader of the UCP and your new premier, Jason Kenney.